Thank you for this honor. It's always great to give a named lecture, particularly at a meeting such as this, so I appreciate the invitation. So, of course, you have to show a picture of Dr. Parton. This was Dr. Parton, Dr. Mike Cook, and myself at a AUA award event a couple of years ago, and you know, Alan was certainly larger than life, and ironically, I think everybody knows that he was a big football player in the SEC, so there's a particular tribute to him in the world of football. So what I really want to talk about is the journey that we have been on urology, understanding genetic and genomic testing, and the history is actually very short, as you'll see. But I want to remind everybody that in 1993, my former mentor, Dr. Lenihan, really pioneered the first genetic basis for kidney cancer. So we've kind of been knowing about genetics in urology since the mid-1990s, but clearly the major impact has really been with the #1 cancer in males, which is urology. So I want to sort of take a walk along the fact that genetic testing is really closely aligned with the discovery of the breast cancer genes. So back in the 1800s, there was a French surgeon who observed breast cancer in his wife's family. And then in 48, a British researcher looked at family trees of more than 450 people with breast cancer and showed, hard to believe today, that in the mid-1940s, breast cancer can run in families. Big breakthrough by Dr. King at UC Berkeley. She noticed that breast cancer was more common in some families, and using data from an unrelated oral contraceptive study suggested that maybe there was a gene in there. Well, then the race was on. In 1990, she actually mapped the BRCA1 gene on chromosome 17. Myriad jumped in the deep end of the pool, and there was a race apparently between a bunch of people, and Myriad got across the line first, cloned the gene in 94. They cloned the BRCA2 gene in 95. They patented both genes in 94 and 95, and through the end of the last century, they were the only company that was allowed to do any type of genetic testing using BRCA1 or BRCA2. And just as a background, BRCA1 and 2, they are tumor suppressor genes that help prevent cancer by helping to repair damaged DNA, and when they're mutated, the risk of having a malignancy goes up. If you look at BRCA mutations, it's between 1 in 400 and 1 in 500 in the population. However, as you've heard many times, the Ashkenazi Jewish population from Eastern Europe has a very high frequency and a very high burden of both breast, ovarian, and prostate cancer. So basically, I love this as a cute little cartoon here. You have a normal BRCA1, BRCA2, you have genomic stability in the cell. If they are mutated, you have genomic instability. So it shows the importance. Again, these are just one of tens of thousands of genes that we have, but they become very important. This is incredible when you look at this. You know, this is just page after page after page after page of genetic ATGC matches. So this was actually the chromosome 13 patent that went through in 1995 for the BRCA2 gene. So the NIH has something called the BRCA exchange. And again, the BRCA is an abbreviation for breast cancer gene. There are over 20,000 unique BRCA1 and 2 variants. However, a panel of experts basically narrowed it down to about 3,700 variants are known to cause disease. Now, this is important because direct-to-consumer from certain companies does not look at hundreds and hundreds of genes. They only look at the founder gene. So when a patient says, oh, I paid company X, I sent them a saliva sample and I got my BRCA1 and I'm good, well, that's not really true because they're not looking at the whole panel of BRCA1 or BRCA2 mutations. So a lot of this work happened in the 1990s, as we talked about, when it came to breast cancer. But something major happened in 2003, and that was the completion of the Human Genome Project. 3.2 billion base pairs. It took them from 1990 until 2003 to map out the human genome. And I like to write down that bottom, when you say 3.2 billion base pairs, it doesn't register, but you write out 3,200,000,000. It makes a lot more sense. It's a massive project that took 13 years. And again, it was not 100% of the human genome, as we will show you in a minute. Some of you may be familiar with something called Moore's Law, another allusion to a IC chip, where basically the number of transistors on an IC circuit will double every 2 years with a minimal rise in cost. Well, the same thing applied to 1990 to 2003 and beyond with the Human Genome Project. You can see that basically you start at 100,000 and you get down to under 1,000 for sequencing a whole genome. Again, consistent with Moore's Law and computer chips. So the last little bit, it took them, and I don't know why, but it took them another 15 or 20 years to get the last little bit of the human genome that was finally published back in 2022. If you look at our human genome, it's massive, and I love this iceberg, because at the top of the iceberg, we know about HOXB13 and BRCA, ATM check, and all that. But the dark, why is all that DNA out there? Why is there all this non-coding DNA? And I think years and years and years, we're going to figure out what's all that DNA doing out there that doesn't seem to do anything. So we're just at the tip of the iceberg, and as time goes on, I don't know where Dr. Sartor is. I hope he's here, because Oliver, are you here? Okay, because I have a slide for Oliver, but he has a very nice diagram where he and his colleagues showed a long tail of genes. So while we focus on this top number of genes, there is a very long tail of genes, and that's going to continue to grow. They may not be 10%, 20%, but they're going to be out there, and we're going to learn what they do. So what happened in 2013? This was an apocalypse, basically. In 2013, things changed in the world, not only in science, but also in public recognition, when Angelina Jolie was on the cover of Time magazine talking about hereditary breast and ovarian cancer and all of her prophylactic surgery that she has. So as we'll look in a graph a little bit, a woman with a BRCA1 or 2 mutation, 36 to 85% chance of breast cancer, a 16 to 60% chance of ovarian cancer. That's why prophylactic mastectomies and oophorectomies actually have been shown, as Dr. Ryan mentioned, to decrease mortality. But here's the other sentinel event that occurred in 2013. In 2013, the Supreme Court of the United States says that Myriad, you cannot patent DNA. They had a lock on the DNA patent, but they said, the patent law said this is a naturally occurring, even the mutated ones, you can't patent them. So that led to a massive increase in many, many, many newer companies entering the breast cancer genetic testing market. And since they've greatly expanded, you're familiar with many of the companies here. Some are represented. It's a partial listing, but again, this was a sentinel event, 2013. All of a sudden, 11 years ago, everybody can get in the deep end of the pool with BRCA testing. So with that little bit of a background in breast cancer, we're going to come back to it in a minute. What about inherited prostate cancer? Where were we with this in this? Really, this only started in 1954, the idea that you can inherit prostate cancer. Again, these concepts today are like no-brainers, but you got to, again, time shift back to the last century. Early scientific efforts were really focused on genome-wide assays and identification of SNPs. And it's really funny because the SNPs have now come back in, as Dr. Helfand talked about. So they were a hot topic. They went away for a while, and now they're back as a hot topic, looking at single nucleotide polymorphisms. So where's the journey of hereditary breast and ovarian cancer connections? Well, in '54, there was a higher frequency of prostate cancer among relatives of ladies with breast cancer. And they proposed for the first time that prostate cancer may be the male equivalent of female breast cancer. They drew some analogies. They said they're both very common, equal lifetime risk, parallel incidence, no matter which country you went to, and both were, at the time, recognized to potentially be influenced by dietary factors. Looking at population studies in the 1950s, we were able to identify familial prostate cancer in the Mormon lineage in Utah. In 1960, deaths due to prostate cancer were 3 times higher among fathers and brothers of men dying from prostate cancer among other relatives dying from other causes. And in 1992, for the first time, prostate cancer was felt in some cases to be inherited by the good old fruit fly Mendelian fashion in some families. And again, it provided a foundation for further gene mapping. Remember, this is 10 years before the Human Genome Project was actually completed. And they noticed that with a family history of breast cancer, men had a 21% higher risk of developing prostate cancer and a 34% increased risk of developing lethal prostate cancer. So this is where things started to shake it up a little bit, that breast cancer and prostate cancer had a lot of commonality. In 1993, it was the first time that hereditary prostate cancer and the BRCA1 and 2 connection was suggested, at that breast cancer genes actually may predispose to prostate cancer in male carriers. And again, the first Sentinel paper in Lancet showed the risk of cancer in BRCA1 mutation carriers with prostate cancer. Now remember, as Dr. Helfer mentioned, BRCA1's the big dog in the mutation world of HBOC, hereditary breast and ovarian cancer. In our world, it tends to be the BRCA2 gene, which is more active in males. So there was all sorts of work done in the 1990s, as we talked about looking at SNPs and polymorphisms, and everybody was out to identify a SNP at the time. And many of you who've been around, maybe from John's residency program, that HPC2, ELAC2 on chromosome 17 was the first reported prostate cancer susceptibility gene. Got a lot of attention, but subsequent studies basically shows that this particular SNP does not contribute significantly to an elevated risk of prostate cancer. But that didn't stop people from trying to make money. If you went back, advertisements in the New York Times, you can send $300 to a company here, Decode Pro CA, to get, if you had prostate cancer. Again, this was unregulated, 5 genetic variants associated with prostate cancer, a lot of excitement, but really didn't have much credibility going forward. Where did we get really the first major report linking BRCA mutations to prostate cancer was in 1999. And again, this goes back to breast cancer. This came out of the Breast Cancer Linkage Consortium that identified a higher risk of prostate cancer among male relatives of women with BRCA2 mutations. And this really, for the first time, firmly established the association between BRCA mutations and prostate cancer risk in men. Again, that's 1990. That's only 24, 25 years ago. Again, this field exploded. Germline mutations in BRCA1 increased the risk by approximately 1.8, but as you see in the bottom panel, it was the BRCA2 that increased the risk by about 4.6 times. So again, different in women. Women, the BRCA1's the big dog. In men, the BRCA2 is the big dog. But again, this shows that breast cancer and prostate cancer were traveling along parallel pathways. Male breast cancer risk, again, common mutation of BRCA2 over BRCA1, which is opposite, again, of the female risk. So as time went on, and I highlighted at the bottom some work by Alan Parton with Pat Walsh that go back to the late 1990s, there's a concept of familial versus hereditary. At the end of the day, we think that there's about a 15 to 20% association of clustering. In other words, you sniff there's something going on in the family, but when you actually do the genetic testing, you don't see anything. Hereditary prostate cancer is very specific, a subtype of familial prostate cancer consistent with Mendelian inheritance of a susceptibility gene. And age is very important for hereditary prostate cancer. If a prostate cancer patient has a relative who was diagnosed with prostate cancer at age less than 53 years of age, their lifetime risk of being diagnosed with a clinically important prostate cancer goes up to 40%. Whereas if they're diagnosed with a relative over the age of 65, that goes up a little bit, but only about 18%. So contemporary data we have out there, looking at prostate screening in BRCA1 and 2 families. This came from the Bancroft crew over in UK. Basically, you can see that BRCA1 carriers and BRCA2 carriers have increased prostate cancer incidence, increased likelihood of having a positive prostate biopsy. And while the BRCA1 doesn't make that much of a difference in high-risk prostate cancer, you can see that it makes a significant difference if it's BRCA2 positive being diagnosed with a higher risk prostate cancer. So looking specifically at the first specifically inherited prostate cancer gene, HOXB13. Men with this specific mutation, now it's just not any mutation in the HOXB13 gene, and at the bottom of the screen there, you'll see it's a normal gene responsible for, it's a tumor suppressant, and it works with prostate and skin development, so it does have a natural function. But if you've got a specific HOXB13 mutation, you've got a 33 to 60% increased risk of prostate cancer up to age 80. So again, the hallmark of this is multiple members of the family who have prostate cancer diagnosed, usually below the age of 60. So again, this was the first truly identified specific prostate cancer inherited genes. So now we move up to sort of 2005, 2015, where we have a whole new phase of prostate cancer genetic testing. Most of we had done at this time, because of the connections with women and hereditary breast and ovarian cancer, was really on inherited risk in genetic testing. Over the period from 2005 to 2015, somatic testing began to become a big deal, where you actually didn't just look at the inherited genes, but you actually looked at the tumor. This to me says a lot about mutations. You can see that while there's a little bit of a bump for men who have BRCA1 or BRCA2 mutation, for prostate cancer, pancreatic, and male breast cancer, it's huge for ladies with breast cancer. So again, I don't want to say this is a bigger problem in ladies, but clearly the impact of having a mutated BRCA1 or 2 gene in a woman has a much higher risk of having significant morbidity and mortality. One of the take-home messages that we now have in urology is urology should become more focused on detailed family history. Now, let's be fair, you don't have a lot of time to sit down and do all these kind of things, so our corporate sponsors, and this is just an example here of a couple of the different familial screening questionnaires that we can get out there. We need to, as urologists, we need to become more focused on detailed family history, and I'm constantly beating this into my residents. Oh yeah, Mr. Jones doesn't have any history of prostate cancer. I said, okay, what about the rest of his family? They're like, does anybody have breast cancer? Oh, I didn't ask him. Pancreas, I didn't ask him. So it's coming through now in training programs where we're having this more of a big tent view of prostate cancer not just being inherited in the prostate cancer male world, but also other cancers, and certainly in the female side of inheritance. Again, we showed you this. This, to me, was probably one of the most sentinel papers that we've ever seen in metastatic castrate-resistant prostate cancer from Colin Pritchard, showing that these big genes, and again, as I mentioned, Dr. Nicolosi, who works with Dr. Sartor, has that long tail of many other genes that are out there in this HRR pathway. But again, the big ones, BRCA1, 2, CHEK2, and ATM that we start talking about. The original study by Collins said it was about 14–15%. Later on, more and more studies have been done that show that this may be up to 25% of the men with metastatic castrate-resistant prostate cancer have these mutations. And again, we talked about this. If a man has a BRCA1 or 2 or an ATM or a CHEK mutation, that x-axis down there, the chance of them dying is 10 years earlier than if they don't have it. Again, what does this underscore? This underscores the aggressiveness of males with prostate cancer with a BRCA1 or 2 mutation. Again, these are the common genetic germline testing that's out there from all the commercial sponsors. Again, if you look at them, ATM, BRCA, CHEK2, and then they get a little bit wonky down the road. But again, the top ones are covered by each of the companies. We talked about this a minute ago. It's got to be genetic testing and somatic testing in men with metastatic disease. We talked about the impact on somatic tumor DNA testing, helping guide treatment. So why am I showing you this slide? I'm showing this slide because more than one person has walked up to me the last 10 years and said, what the hell do you know about genetics? And I'll tell them, I agree, I didn't stay at a Holiday Inn last night or anything like that. But something happened at Jefferson back in 2014 that sort of got my mind thinking about this. We had an attending, a medical oncologist that came over to us from Fox Chase, who had been doing a lot of breast familial genetic testing and counseling and things like that. And she said to me, you know, what do you think about doing this for prostate cancer? And I'm like, I don't know, tell me about it. So basically, we had started a multidisciplinary clinic back in 1996. So it was very easy for us to incorporate genetic testing. So starting in 2014, we actually started doing some genetic testing, not in the clinic specifically, but when we hit somebody with a family history of breast, ovarian, pancreatic, prostate cancer, we met with the patient and said, look, you're here to be treated for your prostate cancer, but we want to let you know, after you're treated, we're going to give you a follow-up phone call from one of our genetic counselors. And that's kind of the way this whole thing started. So when you go back and you look at prostate cancer genetic testing, nothing was going on before 2016. In fact, if you wanted to know anything about inherited risk of prostate cancer, looking at genetic testing, you had to look at the HBOC, the Hereditary Breast and Ovarian Cancer Guidelines. Again, coming back to this connection between prostate cancer and breast cancer. So there was nothing in any of our NCCN guidelines. For the first time in 2016, it was mentioned if you got a family history of BRCA1 or BRCA2, maybe screening, you should think about screening a little more aggressively. In 2017, for the first time, there was actually specific language in there about familial and hereditary genetic risk considerations. By 2018, it was considered germline testing, and by 2020, germline testing was recommended based on the risk of somebody having high-risk prostate cancer. Again, this is 8 years ago. This is not, going back to the last century. So based on this, we did something very interesting. In 2017, we conducted the first international consensus conference on the role of genetic testing for inherited prostate cancer. This was a very large group. We did a follow-up in 2019 that we'll talk about. But why do we need to do this consensus? Why do we do this in 2017? If you look at this timeline, all the things we just talked about, higher rates of prostate cancer with Lynch syndrome, HOXB13, the Supreme Court naturally, prostate cancer multi-gene testing. Remember when Myriad was prevented from being the only one to do BRC testing, you now had all these multi-gene testing. It used to be you had to order one gene. If you want to know if they had a BRCA1 mutation, you only order one gene. We now had multi-panel genetic testing that became available in 2015, 2016. So these were all the reasons that we said, hey, we kind of think we need to do a consensus meeting. So what we did was set up basically a working group and set up the Philadelphia Prostate Cancer Consensus in 2017. Here is the group. This was our paper that was published. And the representation was eclectic. We had 120 representatives. We had urology, medical oncology. We had breast cancer experts. We had GYN experts. We had patient advocate groups. We had patients in the audience participating. We had NCCN people, NCI people, ACS people. And in fact, I wish Oliver was here, but you can see Dr. Sartor was sitting there, Dr. Walsh sitting there as well. And of course, running around confused was Dr. Crawford here in the background trying to find us, getting to the meeting late probably. But again, we really brought together a very, very nice group. And we came up with a bunch of recommendations based on this concept of multi-gene testing, not one gene here, one gene there, but the genetic panels. And this has all been replicated in many other publications over the years. But you see the big ones here that were recommended in yellow. We planned and did a follow-up to this because after we set up what are the important genes, we then talked about exactly getting into family history, talk about collaboration with genetic specialists, and we came up with additional guidelines that were published in JCO. And actually, we had a 2021 consensus plan, but there was a little problem in 2020 that many of you may be familiar with that sort of redirected all of our activities. And actually, I'm a little bit sad because the 2021 was going to focus on the African American population with genetic testing. So where have we been with this journey the last 5 years? I really think that prostate cancer genetic testing has been a major driver for all of our drug development clinical trials. I got this nice little graph from Maha Hussein going back from the 1940s until 2020, metastatic castrate-resistant prostate cancer. These were the landmark approvals. But notice what happened after 2020. Olaparib, rucaparib, the combinations of PARP inhibitors and androgen receptor pathway blockers. This is major. I mean, this is major stuff, and this is only a couple of years ago. And again, what does this all go back to? This all goes back to BRCA1, 2, and breast cancer. So PARP inhibitors were the first synthetic lethality targeted therapy. They were a class of drugs that inhibited the poly-A ribose polymerase pathway. And basically what would happen is with PARP, if you had a mutated BRCA1 or 2 gene that you didn't have a lot of stability, the PARP pathway would become activated and kind of rescue the cell from going down the path of destruction towards tumorigenicity. So people figured out, hey, this PARP is saving these mutated BRCA1 or 2 genes that are causing a cell to become tumorigenic. Not always, but most of the time. And this PARP was like the rescue swimmer, like from the Coast Guard. What if we block the PARP? Maybe we could do well. And again, about 50% of patients with this do respond to it. But it's got to be for the DNA repair pathway genes. So it's very important to understand, really, you got to go back to some basic science from college or a medical school about this. Now, this concept of synthetic lethality still drives me crazy. I could show you 17 different diagrams about all the different PARP pathways and how everything comes in. And I think Emmanuel Aranadakis, who's up in Minnesota right now, showed me this very simple this thing here that you see. If you've got a mutated BRCA1 or BRCA2, PARP can come in and allow that mutated abnormal cell to continue to grow. But if you block the PARP, that abnormal cell could not continue to grow. So the first PARP inhibitor was in 2005 that was developed. It was not until 2018 that olaparib was the first PARP inhibitor approved. Guess what? For ovarian cancer, that was the first approval. By 2021, olaparib had 7 indications across 4 tumor types. Again, this breast cancer, prostate cancer connection. One of the common challenges that we do have with the whole family is this myelodysplasia, although it's rare. As a medical oncologist, as a urologist, I'm not a medical oncologist. We'll do enzalutamide and Abi and apalutamide. I get really nervous with the PARP inhibitors in our world, so we let the medical oncologists do that because myelodysplasia is rare, but it does happen with a high frequency. So May of 2020, almost back-to-back, olaparib and rucaparib were approved. That's 4 years ago. Okay, we talk about these things so commonly now. These drugs have only been available in FDA approval status for the last 4 or 5 years. Again, I showed you this earlier. Genetic testing gets us all these drugs down here, shows that patients are eligible for it. One example of clinical trials and these pathways. I mean, this is the magnitude study, just one of many studies I can show you that looks at HRR panels, BRCA1, BRCA2, others, randomized if you're positive for a mutation or not, and that led to the approval of these combination therapies. And again, olaparib, rucaparib, pembrolizumab, all the niraparib, Abi, the olaparib, Abi, the tilazaparib, Enza, again, all down the same pathway, identical pathways that we see in breast ovarian cancer. Guidelines for genetic testing. I never heard anybody use the word scoping before, but this is the first time I know what a scoping is. So it's in all the guidelines now for genetic testing and prostate cancer. And again, it's not just the inherited genetic testing, but it's also the somatic testing. Again, these are just general germline recommendations from American College of Medical Genetics and Genomics. Again, look at the things. Greater than 3 first-degree relatives with prostate cancer, more than 2 relatives with breast cancer, all metastatic prostate cancer, whether it's newly diagnosed or castrate-resistant, intraductal, somatic tumor sequencing, et cetera, AUA guidelines, which were amended, again, have a lot of recommendations in there, both for hormone-sensitive metastatic prostate cancer. That's something we don't think a lot about, but hormonal-sensitive, newly diagnosed de novo hormone-sensitive prostate cancer, again, now has recommendations for testing. So there you could go here with tumor testing, blood, cell-free DNA, and saliva. Actually, our genetic counselors at Jefferson give people a little bottle of scope. They do a squish in a clinic. They don't even draw blood. They spit, and they send it off to one of our colleagues in the company. So what we have here are rapidly evolving recommendations. Again, the most critical, BRCA1, 2, HOXB13, ATM in check. But again, long tail after that. All metastatic and high-risk disease should have germline testing. It directs the therapy of PARP inhibitors today. I caution everybody, be careful. I don't want to mention the company because I don't want to get a lawsuit, but there is a company out there. You can just go to a website and send them a saliva sample, and they'll tell you you don't have BRCA1 or BRCA2. Our patients really have to be warned that that's not really good. The FDA approved them, but it's not really great. And again, counseling, I think is really important. And again, most of us are lucky enough to be in an academic center with a lot of genetic counselors. I thank you all for your attention, and I appreciate the opportunity and the honor of the Parton Lecture. Thank you.